it's now streaming live on YouTube.
The announcement for future lectures, sir.
Yeah. Jason, are you connecting? Sending the link?
Yes, sir, I'll do that.
Yeah, so that I can, once they are also on YouTube, whoever wants to, then I'll start the announcements.
Yes, sir, posted.
Posted, huh? Yeah, posted. 44. Good afternoon, friends. Along with these lectures, we have added one more lecture. Today, we have Dr. Neha Desai is going to speak on obturation techniques. And ma'am, are you going to take today the failures or tomorrow along with rubber dam?
Today.
Today, okay.
I'll be talking about the failures. Majority of them are covered. So the obturation related errors and failures, and then I'll be talking about the emergencies in current scenario.
Okay. So today, Dr. Neha Desai is going to speak on obturation and emergencies in the current scenario. What treatment can be given, the obturation failures. Tomorrow, that is on 10th of April, she is going to speak on application of rubber dam and its uses, how to apply, where indicated, and where it is not indicated. On 11th, we have Dr. Mayank Doshi for photography, dental photography in the anterior aesthetic zone from 3:30 onwards, and seeing all your good responses on Zoom on 12th of April, that is on Sunday at 12 o'clock. We have Dr. Hiren Desai speaking on the Facebook, its use and application in dentistry, the Facebook transfers at 12 p.m. in the afternoon. 12 p.m. in the afternoon, it's on Zoom and YouTube Live. And then on the same date, 12th at 3:30, we have Dr. Amit Gupta speaking on bone grafts and bone materials used in dentistry during implants. That's on Sunday 12th. And 13th, Monday, we have Dr. Manish Chitnis speaking on financial management in the crisis of COVID-19. So these are the upcoming lectures. Thanks a lot, everybody, to be a part of this interesting series of webinars conducted by Mumbai West Suburban Branch, totally free of cost.
Yay!
Till date, all the webinars, we have reached approximately more than 1,000 participants, 1,000 people, more than 1,000 to 1,500 who have been watching this series and attending this series. Thanks a lot, all the participants. Thanks, Dr. Vinayak Shirshekar, Dentex 3D, for being a part of this a series of webinars from Mumbai West Suburban Branch. Here, I would like to thank the dentist of our fraternity and who are the members of MWSB, Mumbai West Suburban Branch, who have donated certain amounts for the crisis where we would like to help the Nair Dental Hospital, where they had asked for the personal protection kits, which was supposed to be delivered to them. And there is good news that we have received a thanks letter from the Dean of Nair Dental College saying, thanking us for helping them out to donate the PPEs. We have donated 200 PPEs, personal protection kits, and 50 facial shields from our side. This is all because of the donations, the help which all the members of Mumbai West Suburban Branch has given. Thanks a lot to everybody. Yeah. Dr. Neha Desai, you can take over and start because it's 3:30 now.
Yes.
Okay, thanks a lot. Dr. Jashan? Dr. Jashan?
Yes, sir.
See this Dr. Mikita Shah on webinar 1 wants
Yes,
old
sir.
webinar.
I was just checking that, sir. I'll do it.
Yeah, please. Because they are showing it's an old version, old
Yes, sir.
webinar.
Yes, sir.
Yeah. Ma'am, just 2 minutes, huh? Because I think that there is some issue with the
Yeah, no issues.
YouTube link, I suppose.
Yes, sir. आज का ही है, sir.
ये आज का 10.
Yes, sir. It's complete. आज का ही है, sir. I confirm. You can continue with the lecture, sir.
Ma'am, you can continue with the lecture. It's the same one. Okay, continue.
Okay. Okay. Thank you. Good afternoon, everyone. Once again, we are together. Thank you very much, MWSB branch, once again. So starting with continuing our journey into the endodontic procedure of root canal treatment, we begin with diagnosis, decision making, patient selection, and access opening. After that comes debridement. This is the endodontic triad. The old endodontic triad, which was considered earlier. Now there is a modification that we would be coming to later on. So after doing diagnosis, treatment planning, access opening, cleaning, and shaping, now we have reached the obturation of the root canal space. So we have debrided well, we have disinfected our canals well. Now it's a time to seal the apex. There are two components when we are doing an obturation of the root canal space. We use Gutta-percha cones and we use sealer. But why do we require sealers? The reason being Gutta-percha cones, the Gutta-percha has no ability to adhere to the root dentine walls. So we need a substrate which would hold the Gutta-percha close to the root canal wall and prevent any fluid seepage inside, and hence give us a fluid tight seal. So that is the reason we require a sealer as a medium, as an adhesive material for the Gutta-percha obturation material. These are some of the ideal properties described by Grossman. According to that, the mix should be tacky when mixed. It should be easily carried onto the Gutta-percha point. It should make a fluid tight seal. There should be no solubility of the sealer in the liquids, so that we ensure that there is nothing else going into our cleaned and packed root canal anymore. It should be radio opaque so that we can trace it on the radiograph. The particles of the powder should be very fine so that they mix easily with the liquid. They should not shrink upon setting. It should not discolor the tooth structure. It should be bacteriostatic, or at least discourage the bacterial growth. I'm sorry, there is a typing mistake here. It should discourage the bacterial growth. It should set slowly, giving us enough working time. It should be insoluble in tissue fluids. It should be well tolerated by the periapical tissues, and it should be soluble in common solvents if at all we need to remove it. So talking about some of the prominent root canal sealers, the conventional and most popular ones, the zinc oxide eugenol based sealers, they have been classified in many ways. We would be just going as per the usage. So first we'll talk about the zinc oxide eugenol. It has low shrinkage. It has long-lasting antimicrobial property, radio opacity, and handling. These are the advantages it has. It's one of the most popular sealer. We have been using it since generations, even till date. The problem being is it is very highly soluble and it has poor sealing ability. It is soluble in the body fluids. So within 48 hours of setting, it starts, the dissolution starts after 48 hours of setting in the fluids. So the sealing ability is questioned, but yes, again, if it is used carefully, if our preparation is proper, if the apical taper created by cleaning, by shaping of the root canal is proper, then most of the times it gives us very good results. The most popular one amongst them, again, and the most documented one is pulp canal sealer, extended working time, which is still very, very popular. Another disadvantage of zinc oxide eugenol based sealers is they do not, they interfere with the adhesion of the composite restorative materials onto the dentinal wall. But if the root canal cavity is cleaned properly, this issue can be taken care of. Other sealers, tubely sealed, Rickert sealers also being very popular. N2 and endomethasone are also zinc oxide eugenol based, but they contain formocresol in them, and hence their usage has been discontinued now. They are not used anymore. Then we have calcium hydroxide based sealers, Seal Apex and Apexit being the popular ones amongst them. The disadvantage, or rather a catch-22 situation with calcium hydroxide based sealers, is that when you, the reason why we use a calcium hydroxide based sealer is we want the calcium hydroxide to act in the periapical region. Now, for this to happen, the calcium hydroxide ions have, calcium and the hydroxyl ions have to be leaching into the periapical region. Now, if they are leaching out, that means we are losing our apical seal. So it doesn't serve the purpose in the long run. So the apical sealing ability is always a debatable issue with the calcium hydroxide based sealers. That is the reason, again, they are not very popular, or they should be used cautiously. Of course, when there are cases where the patient is not available, if they are NRIs, they have to go soon, and you don't have enough time in hand in case of a necrotic case or an infected case. In such cases, these sealers are helpful, but then we have better materials, which we would discuss later on. So that is one indication where calcium hydroxide based sealers can be used. Otherwise, there are many other options available. They should be preferred. Silicon based sealers, RecoSeal, Gutta-Flow 2, they are again very useful, but then they do not have very good, they are not very popular for their handling characteristics. Gutta-Flow being a little on the expensive side, but the advantage with Gutta-Flow is that it has no setting shrinkage. It has got Gutta-percha powder mixed in the resin matrix, silicon filler matrix, and it sets at the room temperature. It's called Gutta-Flow because it is flowable at room temperature. It needs no heating. It is available in a capsule delivery form. It has to be triturated just like an amalgam capsule, and it is to be carried into the canal with a carrier gun. Hence, it has a bit of an equipment and armamentarium involved. The cost goes high, but at the same time, there is no shrinkage here. So that is the benefit. The modification of it, Gutta-Flow 2, comes in a dual syringe with an auto mixing syringe attached to it. So Gutta-Flow is a very good alternative to be used. Glass enamel based sealers are not used anymore for their high fluid solubility as well as difficulty in retrieval at the time of retreatment. Methacrylate resin based sealers had issues with shrinkage again, so they are also not used anymore. The epoxy resin based sealers are the most popular right now for their excellent dimensional stability, the flowability, radio opacity, biocompatibility, handling characteristics, long working and setting time, and better adhesion to the dentinal walls. The only disadvantage being it is hydrophobic and it's a little difficult to retreat, but then we have better ultrasonic devices nowadays. At the same time, our improved irrigants also, and the irrigation regime with activation efficiently can remove even the epoxy resin based sealers. And they do not have chemical adhesion to dentine or gutta-percha, so there has to be a micromechanical adhesion developed over there, for which we follow the entire, this is also one of the reasons why we follow a proper irrigation protocol, so that we have clean dentinal walls free of bacteria as well as smear layers, so that we have very good resin tags when we are using these resin based sealers. Smear layer is not much of an issue when we are using zinc oxide eugenol based sealers. AH plus being the most popular one in this. AH26 was the old variant which used to have silver in it, and due to silver there used to be discoloration. And hence AH plus was developed, which did not contain silver, and it's one of the most popular and the most documented sealer again, and most biocompatible as well. There is a newer variant of sealers available now in the form of bioceramic sealers. These, according to the manufacturer's claim, they are holier than thou materials and absolutely flawless, which is not the case. However, the manufacturers claim that it is extremely biocompatible. It has got very good antimicrobial activity. It has got very good flow handling characteristic. It has a long setting time. It is radio opaque. Hydrophilic is the major advantage because it sets in presence of moisture. It chemically bonds to the dentine and GP. It makes hydroxyapatite molecules at the interface. That is again a big advantage. The fracture hardness is high and it is osteoconductive. It does not have any adverse inflammatory reaction on the overfill. And it has slight expansion on setting, contrary to the other sealers, which have a tendency to shrink. The manufacturers claim that it is not so soluble and it is easily retreatable, but that according to the studies is not correct, because bioceramic sealers have exhibited, they have shown high solubility in fluids. And during retreatment, the manufacturers recommend removal with the help of using chloroform, which is not allowed in our country anymore. The chloroform is not available freely. Hence, retreatability becomes an issue in as far as the regulatory concerns are present in our country. The mechanism of action of bonding of bioceramic sealer to root dentine. So when we apply a layer of the sealer, the dentinal tubules, a bit of the sealer also flows into the dentinal tubules, where the minerals are infiltrating into the surrounding dentine matrix, the surrounding tubular structure, where they create hydroxyapatite molecules. And hence there is a chemical adhesion between the sealer and the root surface. The brands available in India and their cost. Endosequence BC sealer is expensive. It is available, but it is expensive and it has to be imported, so it takes a bit of a time. The approximate cost is $240. It is pre-mixed, available in a syringe. The advantages are it is very time saving, because the handling characteristics are very, very nice. You just have to inject it into the canal. The correct proportion of ingredients, and it's a very homogeneous mix. There is no wastage here because it is in the syringe form. So it's very easy to use, very user friendly. MTA Filapex it comes as two paste mix at the same time, as a dual syringe with auto mixing tip as well, which falls in the range of 3,600 to 2,100. It is cost effective. Bioroot RCS is available. Quantity is around 1 to 2 grams, which is available for 11,000 rupees. It is available in powder and liquid form. Hence, Endosequence BC sealer has an edge over all of these because it is pre-mixed, it is homogeneous, there is no wastage. So these are the advantages. But at the same time, cost is a factor. I mean, it just doesn't work out as far as economics go. And with the solubility and retreatability issues, I have reservations using the bioceramic sealers yet. The MTA-based sealers have mineral trioxide aggregate, salicylate resin, natural resin, bismuth, and silica in them. It stimulates mineralization. We all know the benefits of MTA. It encourages apatite-like crystalline deposits along the apical and middle thirds of canal walls, as we saw. And it can be used with cold lateral compaction as well as warm Gutta-percha techniques. This can be used in cases with periapical infections or where we do not have a sufficient follow-up period. As I mentioned earlier, instead of using calcium hydroxide based sealers, it is always advisable to use MTA based sealers, because calcium hydroxide is a byproduct of setting reaction of MTA. Hence, we are getting calcium hydroxide ions, At the same time, we are not compromising on the apical seal. So MTA based sealer is a material of choice in such cases. At the same time, if there are minor perforations along the wall, there are minor strip perforations or apical transportation, etc. Again, this is the sealer of choice in such cases. Talking a bit more about endosequence BC sealer, it is calcium silicate based. It contains zirconium oxide, tricalcium silicate, dicalcium silicate, colloidal silica, calcium silicates, calcium phosphate, monobasic, and calcium hydroxide. It has got nano-sized particles in it. It is pre-mixed, available in a syringe. And the delivery needle, the particle size is just 2 microns, and the delivery needle diameter is 0.012 inches only. That is a very, very small opening through which the paste has to be really pushed into the canal. Hence, it causes a lot of hydraulic pressure, and this helps in achieving the hydraulic single cone Gutta-percha obturation technique. We would be discussing about that later on. They have a concept of endodontic synchronicity. By endodontic synchronicity, the manufacturers mean that the file that is used, the Gutta-percha, the master Gutta-percha has to be of the same file system, and it has to fit in the canal with very little space for the sealer to flow around it. They also have dedicated Gutta-percha, BC Gutta-percha points, which have got surface treatment, specific surface treatment done on them. Coming to the Gutta-percha points, the Gutta-percha that we use for obturation, there are standardized and non-standardized Gutta-percha points. These are the standardized points. They follow the ISO standardization. They are available from number 15 up to number 140. Then there are non-standardized Gutta-percha points, which follow a different naming system. Then there are Gutta-percha pallets, which are used for the backfill guns in case of warm vertical compaction. The non-standardized Gutta-percha are greater taper points, and they are named medium fine, which has got a taper of 2 to 3%, fine medium, which is 4 to 5% taper, medium is 6 to 9% taper, and medium large is 10% taper. The Gutta-percha has two crystalline phases, and it is available in alpha form and beta form. The alpha form is brittle at room temperature. It becomes gluey, adhesive, and highly flowable when it is heated. This is used in Gutta-percha, the thermoplastic Gutta-percha technique. So the Gutta-percha pellets that are there, they are in alpha form, whereas the Gutta-percha points are in beta form, but when they are heated, they convert into alpha form. They are stable and flexible at room temperature. They become flowable and less adhesive when they are heated. And when they are cooling down, Gutta-percha has a tendency to shrink. The Gutta-percha points are used for cold lateral condensation as well as for warm vertical technique as well. Let's come to the obturation workflow. The master cone selection. After we complete the cleaning, the shaping of the root canal, and when we are starting the final irrigation protocol, before that we do the master cone selection. So our master apical file, the master cone is as of the same size as that of a master apical file. We saw yesterday how do we determine the master apical file by doing apical gauging. During final irrigation protocol, take the master cone radiograph. So the master cone selection has to be done in a moist environment so that we do not have any false tug-back. Now, the protocol that I follow is usually I do the master cone selection during the final irrigation activation protocol, because that is to minimize the contamination of the master cone. When we are just done cleaning the canal, and if we haven't done the final irrigation protocol yet, that means there are still debris and bacteria present in the canal. I wouldn't like to take the master cone radiograph that time, or the cone fit radiograph, because there is a chance of more contamination of the master cone. So after first two cycles of first two sets of sodium hypochlorite irrigation, the canal is relatively clean now. I put a fresh calcium hydroxide, the sodium hypochlorite solution, and I take the cone fit radiograph at that time. And after that, I disinfect the master cone. Since my canal is clean, I have put my the Gutta-percha point has to be cleaned, disinfected by immersing in sodium hypochlorite solution for just 1 minute, not more than 1 minute, because otherwise there are salts which are being formed onto the surface of the Gutta-percha, which again leads to improper seating into the root canal at the time of final obturation. Hence, I use it in between in a clean cavity which already has sodium hypochlorite in it. By the time I take my rubber dam is on, so there is no question of other contamination happening at that time. I take the radiograph. In the meanwhile, my Gutta-percha point is approximately there in the canal for 1 minute already. After that, I just wipe it with a moistened cotton pellet in hypochlorite, wipe it with distilled water, and then keep it, not with saline, because again saline is a salt, it has got salt in it, so again there is a risk of precipitates deposition on the Gutta-percha. So after that I dry my Gutta-percha point and then I keep it on the tray. So Gutta-percha disinfection part is taken care of. After that, dry the canal preferably after the final irrigation protocol is completed. Dry the canal preferably with isopropyl alcohol, and after that paper points. Proceed with obturation. After obturation, clean the pulp chamber thoroughly, and after that proceed with the coronal seal. Ideally, permanent restoration should be done in the same visit as that of obturation. If that is not possible, at least a coronal seal has to, orifice sealing has to be carried out that time. So the orifices should be covered with a layer of glass ionomer cement, ensuring that there is no more contamination happening in case the patient cannot come back to you in a near future. And then you can proceed with temporary cement on top of the layer of glass ionomer cement. Master cone selection, as I said, it is the same, the size is same as of that of the master apical file. To calibrate and to ensure that we have the same apical diameter, it is advisable that we use a GP gauge. It is a diameter gauge in which there are certain diameter holes present on the devices in which we place the Gutta-percha cone. In this device, it has a blade in it incorporated. You just slide this around and it trims the Gutta-percha at the tip. And over here, you have to cut the Gutta-percha point with the BP blade. This is done because Gutta-percha points are hand rolled. So there is a chance of error in them. Sometimes even though they are ISO standardized, there is a chance of error. And to avoid any errors, we ensure that the apical diameter is uniform by trimming it with these gauges. And these are helpful in case of non-standardized Gutta-percha points a lot, because non-standardized Gutta-percha points do not have any fixed size. They have generalized sizes. Hence, you need to trim them according to the required diameters. That is an advantage with the non-standardized Gutta-percha point as well. It reduces your inventory a lot. When you are using standardized Gutta-percha points, you have to keep all possible sizes, and some of them are used more frequently, some are not used, they just lie unused most of the times. But again, you have to keep things in your inventory, you never know what you require when. In that case, the non-standardized Gutta-percha points are very useful because it reduces your inventory, you can cut them to the desired diameter. So with less number of Gutta-percha points also, you can serve a lot of purpose. The length is marked depending on the depth gauge on the cone, and the seating is confirmed, the tug-back is confirmed. Now regarding the cone fit, there is something called a true tug-back and a false tug-back. Now what is a tug-back? Tug-back is when, if we are holding our finger in our hand like this and you apply gentle pressure, then it is difficult to move the finger away from it easily. Similarly, when the Gutta-percha is seated into the canal, it has to have that sort of a nice snug fit inside. It should have a slight resistance at the tip. Now, How do we know that it is getting bound at the tip only and not somewhere in between? This is a false tug-back. One way of reducing this is by doing the cone fit in a moist canal, so that there is no friction on the walls and it has a easy passage till the apex. Another reason is, many a times what happens is, we have, as I said, the Gutta-percha is hand rolled. And suppose we have created a canal taper here of 6%, and I'm using the same 6% Gutta-percha point here. There is a chance that it could be bulky somewhere in between, and I may get a tug back here. Though I have reached the apex, I may get a false tug back somewhere in between. This may not be easily appreciated on the radiograph. Hence, to remove this error, we use one taper less. So if my preparation taper is 6%, I would go for a master cone with the same diameter as that of the master apical file, but 1 degree less of taper. So I would go for a 4% taper instead of 6% taper. So that would ensure there is no friction along the wall. Coming to the cone fit checklist, standardized or non-standardized GP points are used. They are, they are again, the diameter is confirmed with the GP gauge. Mark the working length on the master cone, check for the tug back, remove the cone to check for any wrinkles, any deformities on it, reinsert the GP and take the master cone X-ray, disinfect the Gutta-percha point, and then proceed with the obturation procedure. Now, disinfection and storage of master cone, as I said, it has to be stored in the container of 5.25% hypochlorite for just 1 minute, no more than 1 minute. But as I said, what I follow in my protocol is, after I have my canal which is filled, which is already agitated, activated irrigation has been done twice in the canal. After that, I put the sodium hypochlorite solution in the canal. I am taking the master cone, I wipe it dry with distilled water, and I'm keeping it on my instrument tray. So this is my instrument tray, on which at the corner of my instrument tray, I mark and I write down the working lengths of my working lengths of the canals. And I keep a tray here, on a small tray, on which I keep all the respective Gutta-percha points. So this keeps them clean. At the same time, they are sorted. You don't misplace them, you don't mess them around. Otherwise, there is no point taking a master cone fit radiograph. If you mix up your Gutta-percha point, then the purpose of taking a cone fit radiograph is not served, because sometimes it happens that we have used a different taper Gutta-percha point in different canals. So be very careful about not mixing up the Gutta-percha points. This is the method I follow, but again, each to his own. So you can work out your own way of doing things. Drying the canal with isopropyl alcohol solution, and after that with paper points. Paper points are also helpful in final confirmation of the working length. Sometimes if we have gone beyond the apex, the Gutta-percha, the paper point will have the blood spot, the red discoloration at the tip, which would be an indicator. Hence, go back, recheck your working length and proceed accordingly. Another reason why I do the cone fit radiograph during irrigation protocol is, either you can do it before that. As I said, there is nothing wrong in it. Then you will have to immerse it in the solution, the hypochlorite, for 1 minute afterwards, or else in between the protocol, because once I have completed my cleaning irrigant activation protocol and I take my master cone fit radiograph, what if I'm short of the working length? Then again, I have to redo the whole protocol again. And the protocol that we discussed yesterday takes approximately 20 to 25 minutes. So like almost half an hour again, after reinstrumentation of that apical, whatever little requires another attempt at reinstrumentation, makes no sense. Hence, before you start with your irrigant activation protocol at the end, before that you take your master cone fit radiograph, so that you ensure that your master cones are fitting properly, and after that only you proceed with the irrigation protocol. Now coming to different techniques of obturation. The cold lateral compaction, there are so many obturation techniques. Conventionally and most popularly used cold lateral compaction, the warm compaction, in that we have vertical and lateral compaction techniques. continuous wave compaction technique, thermoplastic gutta-percha, injection, also known as squirting, carrier-based gutta-percha, Max-Pedden, mechanical compaction, chemically plasticized gutta-percha, custom cone. These two were used earlier, they are not used anymore. Chemically plasticized gutta-percha were used to be dipped in chloroform, and after that it used to be used, but we are not using that anymore. So these are the more popular methods: cold lateral compaction, warm vertical compaction, continuous wave compaction technique. And yes, carrier-based gutta-percha also is popular, but again, it has got its own cost involved. Coming to lateral compaction, after the master, we carry the sealer inside the canal either with the help of master cone or with paper point. We coat the canal thoroughly with sealer. After that, insertion of the master cone, and then we use the plugger one size smaller than the master cone. We insert it into the canal as deep as it can go. Ideally, it should be 2 millimeters short of the master cone. You place your accessory cones, gradually reduce the spreader size, and you can go on inserting. But it makes no sense to pack more points beyond the middle third. If you are inserting points up to this level, that makes no sense. You might have inserted 10 points, 15 points, but if it is only in the middle and the cervical third, that makes no sense. Ideally, our gutta-percha should end at the cemento enamel junction. Particularly in anterior teeth, this is very critical. Otherwise, if it has gone beyond the cemento enamel junction into the pulp chamber, it will be seen through the crown. So you would see that orangish discoloration through the crown, which is not desirable. Hence, always restrict your gutta-percha obturation up to the cemento enamel junction. Hence, if you have inserted any more cones here, that just doesn't make sense. So after packing the gutta-percha points, we sear them off with a heat carrier material, either the electronic heat carrying device like touch and heat or system B, or else a heated instrument like spoon excavator or ball burnisher. After that, we plug the remaining gutta-percha and pack it nicely into the canal. This is the way we work in posterior teeth. The disadvantage with lateral compaction, we all know, though this is the most popular method, the disadvantage here is we incorporate a lot of stresses into the already thinned out root canal wall. So the risk of vertical root fracture increases again. And if we have given a greater taper preparation, then the risk of vertical root fracture in future increases even more. Then came the single cone techniques, in which we used to just, it became very popular with pro taper gutta-percha points, because the pro taper files came with the same corresponding size gutta-percha points, and it was marketed very aggressively that time, that just one cone and it fills all the voids, or entire cavity is filled, etc., etc. No, the research does not support this. Single cone technique must not be used. Instead of that, you can use single cone. If you have the same size as that of your system that you have used, the last instrument in the system you have used, if you have got a corresponding gutta-percha point, you can use that. Otherwise, it is advisable to go for lateral compaction or vertical compaction. Coming to vertical compaction technique, Schilder's technique is has been described, and it has been practiced very widely, very popularly till now, and it ensures a 3-dimensional obturation. Let's have a look at the video. These are the Schilder pluggers. They have got markings on them. We first check the plugger size. One should be fitting at the cervical level. This should go up to the middle third. And the finer plugger should go up to the junction of middle and cervical third. Ideally 3 millimeters short of the apex. Then we try in the master cone. Once the master cone selection is done, the working length is determined, we trim the tip of the master cone. Approximately 1 to 1.5 millimeter is trimmed off, because we are heating the gutta-percha and we are applying pressure on it. So it is going to flow into the canal. If So to prevent it going beyond the apex, we trim it so that after compaction, it reaches the desired length. The sealer is applied with paper point or with the master cone, and then the master cone is seated. The tip is severed off. It is packed under pressure until it cools down. Then again, the heat barrier device goes in. Some more gutta-percha is heated. After we heat, we wait for a second for it to cool down. Then again we give heat for 1 second, and then we remove the carrier instrument so that the gutta-percha sticks to the carrier instrument and comes out along. This is a final heating with the heating carrier. We heat it, then we allow it to cool a little, again heat for a second, and then take it out so that a chunk of gutta-percha also comes out along with the tip. Now the finest plugger goes in. It packs the gutta-percha inside. Just watch the movement of sealer over here as well as in the lateral canal. After that comes the phase of backfill. So this is a backfill gun which is heated at 200 degrees centigrade, and we keep it in contact with the already packed, down packed gutta-percha for a while, so that that part is of gutta-percha is heated, and the new gutta-percha that we have injected inside fuses with the down packed part of gutta-percha. Gradually we fill the canal bit by bit. We wait with the heated tip, we wait for a second, inject, compact, wait for it to cool down. Again inject, compact, and wait for it to cool down. We are limiting our obturation at the cemento enamel junction only till the orifices, not beyond that. We do not want gutta-percha mushrooming out into the pulp canal, the pulp chambers. This is Schilder's technique. Now there is a modification in Schilder's technique. It's a little time consuming. Hence, a new modification which came up was continuous wave of compaction.
This motion separates the gutta-percha mass, segment apical to the heat carrier, and the segment long. The carrier is then removed from the canal space. The apical portion of the separated gutta-percha mass remains in the canal space. The rest of the gutta-percha comes out of the canal space with the carrier. A small 3-fit plugger is inserted into the canal space and used to tamp down the apical plug of gutta-percha. The plugger is removed in the final step of the continuous wave technique, leaving the apical
Here is a short clinical video of the obturation technique that I follow. This is the palatal canal of tooth number 26. This is a heat carrier instrument. That is a mass chunk of Gutta-percha that came out along with the tip. And this is the plugger, which is packing the Gutta-percha in the canal. And the down pack is done. I'm sorry about this yellow band on the screen. This is a touch screen laptop and something is wrong with it. So the screen just keeps on popping some colors somewhere. So the down pack is done in all the 3 canals in this. After that, this is the backfill gun. And that mass of Gutta-percha is being compacted again inside. A larger diameter plugger at the end, which was packing it further in. And this is how we fill the canal completely. Now comparing the single cone lateral condensation and the thermoplastic as Gutta-percha technique, this is a study where the dye penetration leakage, the dye penetration was studied. And this was the cross-sectional image of the apex of all the samples used in the teeth used for the study. So the coronal portion, the middle portion, and the apical portion. This was with the single cone. There is a mist canal in the middle third, and at the apex, the dye has leaked all around. This blue color seepage indicates dye. That is where these are the channels through which micro leakage can take place. If so, basically what happens is, after doing obturation, these teeth are immersed into methylene blue dye, and after a particular number of immersion into the dye, they are cut off at several levels, and then they are studied. So wherever the dye has penetrated inside from the tip, from the root apex, that is a route even the bacteria follow. So around this, there is a fair chance for a lot of micro leakage. This is a thermoplastic carrier-based Gutta-percha called Gutta-fill, around which, again at all the different levels, around apical level, here there are no voids and there is less dye penetration. Compared to this, the density over here is less. Coming to lateral condensation, over here in the middle third itself, you can see there is a lot of penetration. So not just at the apex, here it is very, very dense. A lot of micro leakage has taken place here. Over here, up to the middle third, the micro leakage has taken place. The dye can be seen all the way till here. And you can appreciate the voids. This is the master cone, and these are the accessory cones. As I was saying, in the middle third, there are hardly 1 and 2, or maybe third point here, which is fused. But there are plenty over here. It makes no sense if you are packing too many cones in the coronal third, because we require density in this region. This is where lateral compaction lacks. There are a lot of voids in this. Comparatively, this the thermoplastic Gutta-percha fills the canal more uniformly, more thoroughly. And single cone, you have to rely more on the sealer, which is not a very ideal condition. These are the carrier-based Gutta-percha systems. These are also pretty popular in the Western countries, not so much in our country. So basically here, the heat-based carriers are available up to the corresponding master apical file sizes. This system is called thermofill. So it's a plastic carrier on which the Gutta-percha is coated. So after verification, after the canal preparation, the Gutta-percha is heated in a particular, in a specific oven that comes with the kit. You have to preheat the Gutta-percha in that oven. After that, you carry it inside the canal. When it is warm, it flows inside and it seals all the empty space. It fills all the empty spaces. After that, the carrier is trimmed at the cervical level, and then rest of the cavity is filled. Here is a video of a material by Dentsply called Gutta-core. So Gutta-core does not have any carrier beyond the cervical third. So the portion below is just complete Gutta-percha. I don't know, something wrong. Let me just find out. I don't know why the video isn't playing now. Huh.
Gutta-percha obturators helps you achieve a dense 3D film in the most challenging canal systems. Start by checking your final shape with a size verifier. It should fit passively at working length. After performing your final irrigation, turn the oven on by holding the size button until lit. Disinfect your obturator, set its working length, and place in the oven arm. Use a paper point to apply Thermoseal plus ribbon sealer to the canal walls. Wick excess sealer with a paper point. Press the oven arm into the heating chamber and heat on the first setting. When heated, press again to release. Gutta-percha obturators are coated with the same flowable alpha phase gutta-percha that's provided years of predictable fills. Take 7 to 20 seconds system excessive force.
Neha ma'am,
Yes,
ma'am, the video is not seen.
it's not seen.
Yeah, it's not seen. It has gone once again on the carrier-based Gutta-percha slide.
Oh, okay. Let me check out.
Yeah, ma'am, please.
Let me see if it's. Is it playing now?
Yeah, but it is very slow. In fact, it is on the smaller screen.
Yes, yes. But it's. Is it visible on the presentation now?
Yeah, ma'am. Thoda bahut, yeah. Yeah, now it's visible. Now it's visible, I suppose. Ma'am, nothing is seen. Yeah, Astut is seen now.
Okay.
Yeah, fine.
Use a paper to apply Thermoseal plus ribbon sealer to the canal walls. Wick excess sealer with a paper point. Press the oven arm into the heating chamber and heat on the first setting. When heated, press again to release. Obturators are coated with the same alpha-based gutta-percha that's provided years of predictable fills. Take 7 to 20 seconds to place the system in one smooth motion with excessive force. Reaches its working length, use a round ball to set the obturator. This. You can also remove it by bending from side to side without impacting the seal. Gutta-percha obturators remove easily without gutta-percha because they are gutta-percha through and through. You'll see the familiar shredding characteristic whether you're creating post space or retreating. Gutta-percha cross-linked
पापा वॉल्यूम करो
everything you know and trust about gutta-percha with the performance and performance of a dense Tulsa dental specialties obturator.
coming to the concept of hydraulic condensation, now this brings the concept of single cone Gutta-percha again. Hydraulic condensation is recommended by the manufacturers of the bioceramic sealer. So particularly the endo sequence BC sealer. So what they suggest is when you fill the canal a little short, 2 to 3 millimeter short of the working length with this BC sealer, and you place the appropriate size cone inside it, because of the snug fit of the cone, it will because of very little space around, it will just push, as we saw in the previous video, it just the hydraulic forces which are generated, they push the sealer all around laterally, and it ensures that it is filled up to the apex. Now if the cone seating is too tight, then there is no space for the sealer to flow around, hence it has to be slightly loose in the canal, and so that, and it should be seating up to the apex so that there is enough space for the sealer to flow all around. Here is a video of the technique of hydraulic condensation.
After the fitted has been selected for this canal, in this case, size 345 for the full BC cone, I inject first some bioceramic filler in the corner half of the root canal. And then what I would be doing normally is be pushing it down to the sealer. I just want to show you how condensation and placement of the fluid's mass creates adequate rocks to push the sealer forward, fit of the cone, and into the lateral cone. As you can see, slow action creates enough hydraulics to push the bioceramic cement into the lateral canals as well as into this widespread fan in this wall. I think this demonstration really clearly shows the hydraulics and the effective operation that can be using this technique compared to the standard composite.
This seems very promising, very easy, and back to the single cone obturation days. So there are a lot of cases, doctor. I have taken these images and this particular video from Real World Endo website. Dr. Alan Ali Nasse, he is the endodontist who uses this system widely, and these are the cases demonstrated by him. And they have been using the sealer since 10 years. They claim a lot of good success, retreatability and everything, but the literature speaks otherwise. So bioceramic sealers, and again, the cost is inhibiting factor in at present. So they are not yet as popular in India, but yes, they are definitely very promising. And now some of the Indian companies are also coming up with the locally manufactured bioceramic sealer in a similar syringe delivery form. I haven't tried it yet, and as I said, I have my reservations trying it. And if at all I try, I preferably would try the original product than trying the other variant. So whenever I use, I'll keep you all updated. So this was the old concept of using a thinner tapered master cone in a wider canal, and then we fill it up with the accessory cones, or you use a corresponding size cone in case of a single cone obturation, and we fill that. Now here we are back to the same concept of single cone obturation with a little loose fit in the canal for the hydraulic pressure to carry the sealer all around. So this is with the cold, this is what they call cold vertical condensation. And the researchers claim that the bioceramic sealer has got a very good sealing ability and other qualities that we saw earlier. So even if the rest of the canal is not filled with gutta-percha, but the bioceramic sealer, that also serves the purpose very well. In fact, in one of the manufacturers even claim to the extent that you need not use the gutta-percha also. You can fill the entire canal simply with bioceramic sealer, but that becomes very difficult in case of a retreatment. Hence, usage of gutta-percha is recommended. But otherwise, as per the manufacturer's recommendations, you can even go all the way in the obturation just with the BC sealer. So this is the cold hydraulic condensation versus the warm vertical condensation that we do. And this is a schematic comparison again of a lateral compaction. This is vertical compaction where we have more of sealer, but as per the synchronicity concept, since the cone is totally of the canal size, the preparation size, hence there is very little sealer after the hydraulics has taken place. This is a micro CT reconstruction again of a BC sealer case only, where this is a pre-preparation CT. This is post-canal preparation CT. This is post-obturation CT. And then all the three are composite. They all are clubbed together. And this shows that it has been filled as efficiently, almost as efficiently as it was cleaned. Of course, there is a little bit of area over here which remains unfilled. But then it is a very tiny ramification. So that usually should not have any disturbance. These are the cross sections at the apex. The isthmi are filled with the BC sealer, and there are two separate cones used over here. You can even use a BC sealer for lateral compaction with our normal cone as well, if my patients who are willing to pay for it. Coming to the obturation of open apex, the in such cases, as we discussed, very little instrumentation has to be done. It is more of cleaning that has to be done here. Apical plug is created by either MTA, biodentine, or the bioceramic putty. The bioceramic BC sealer also has got the same composition in a form of a packable putty. So that is used for perforation repairs, for a root and filling material, and as a for the apexification procedures as well. So this block here could be either of MTA, biodentine, or a bioceramic putty. iRoot putty is another bioceramic putty marketed by Septodont, if I'm not mistaken. Another issue when we are dealing with these wide apices is when we are packing our material, it is still in a plastic form. It is still tacky. It is not yet a solid mass. Hence, controlling its limit apically becomes a bit difficult. Hence, we need something. When we are compacting the MTA from top, there is a risk of the Gutta-percha flowing out of the canal. For that, a barrier is recommended to be used here. Now, that barrier can be a lot of materials. In this particular study, they have used a PRF plug at the apex. If PRF plug is not feasible, not possible, then we have lipophilized collagen sponge, the cellulose matrices, like Surgicel, gel form, Abgel. All these can be used as an apical barrier material, which is to be packed beyond the working length inside the apex. And against that, we can pack the MTA or the other materials. Now, after doing the obturation, as I said, we have to sever off the GP at the cervical, the cemento enamel junction. We are not letting it flow, just flower out into our pulp chamber. It should be severed off properly. This can be done even with the conventional hand instruments, a heated ball burnisher or spoon excavator, whatever you're comfortable with. Otherwise, an electronic heat carrier device is any day preferable. And afterwards, the cavity, it would be still soiled with sealer, which can be cleaned by isopropyl alcohol or a 10% citric acid solution, and just agitate the solution nicely with a conventional scaling tip that we use for scaling. So use the same scaler tip inside with the ultrasonic energy, and it removes all the sealer from all around the walls. And then you have a nice cavity like this. Only then you will ensure a good adhesion of your restorative material to the tooth and prevent any micro leakages in future. And as I said, a coronal seal is a must in the first appointment itself. Coming to the post-endo restorations, post-endo restoration can be carried out either the whole cavity can be filled with glass enamel cement, but a hand mixed glass enamel cement is not recommended. Instead of that, go for the capsulated cement capsules, which are pre-mixed and which are triturated in an amalgamator, because that gives you the correct properties, the correct consistency and correct proportion, correct properties, and only then it will have its best performance. The powder liquid hand mixing thing does not give a very good coronal seal, and it is not recommended. Or else we can also use resin based core filling materials like Luxa core, Paracore. There are many more available in the market. There are blue colored core build-up materials also available. However, I wouldn't recommend filling up the whole cavity with the blue color. But if it's a posterior tooth, yes, very well, we can do the same. Anterior teeth, we have to use the tooth colored material only. But in case of retreatment, sometimes if you have used a composite, a tooth colored composite core build-up material, it becomes very difficult to you end up creating gouging, because now we don't have that hollow burr drop inside the pulp chamber which will guide you into the walls. Now the whole pulp chamber is filled with one chunk of composite. Hence, it is always good to have either a different color near the orifices and on the floor, or maybe a different texture of material. So either if you're using composite, use a blue color composite on the floor and then fill the rest of the cavity with the tooth colored material, or you can use glass ionomer cement as a base, and on top of it you can do composite restoration. I have had a bad experience. Initially, I used to just do the whole cavity with a composite core build-up material, and once my patient experienced a lot of post-op pain. We waited for a few days with antibiotics, with analgesics, with everything, but there was no reduction in pain. Probably everything else was the same, but I had changed my sealer that time. I usually use AH plus. That time I had changed my cement, my sealer. Probably that was the reason. That is the only thing I can attribute, because I had done many other restoration in that, many other obturations in that period with the same protocol, but I did not experience any pain in any patients except for 3 to 4 patients in which I had tried the different sealer. So that was my prediction, or rather that is what was my assumption, that probably it is that sealer which was not compatible enough, because all 4 cases in which I had used it, I experienced difficulties. After that, I discontinued using it. I went back to AH plus, and I am absolutely loyal to AH plus. I usually do not change. So that's about AH plus. Again, the zinc oxide eugenol based sealers are also very popular. Even till date, a lot of people use it, and it is not an absolute contraindication even if you want to do a composite core, as long as you are cleaning up your cavity this well. This ensures that there is no zinc oxide eugenol sealer remnant inside the pulp chamber anymore, which would interfere. And in spite of that, for an extra layer of safety, we can always have a base of glass ionomer and then proceed with the composite. Now, this study emphasizes the importance of post-endo restoration, or the post-RCF. That is how it is more popularly known. So the percentage of success in endodontic treatment depending on the quality of treatment and the quality of the coronal restoration. This study was carried out by Ray and Trope. This is one of the most landmark studies, and the results were so interesting here. The quality of the endodontic treatment was good, and the quality of coronal restoration was also good. Then the success rate in that case, the success here, the criteria was absence of any periapical pathology on radiograph. So 91% of the cases showed success after 5 years. Good quality of endodontic treatment, but poor coronal restoration led to 44% success only. A poor endo treatment, but a good coronal restoration led to 67% of success rate. And poor endo with poor coronal restoration led to, of course, more failures. So this is very interesting. Even if your endo is poor, but if the coronal restoration is good, then your success is fairly fairly better compared to having a good endo but a poor coronal restoration. So it's very, very important that you do your post-endo restoration very carefully and in a very clean canal. This doesn't mean that we, just make do with an average endo and then do a good coronal restoration. We should achieve for the highest success, definitely, always. And I would just say, कि coronal restoration ठीक से करो ना. That's all. I'm sorry for all these lines. I don't know how they are just appearing all over. So after completing the coronal restoration as well, the root canal part gets over here. So my presentation ends there, but just a few points to ponder regarding the post-endo crowns. Do all the endo-treated teeth require crowns? If I can have some answers from the audience on Zoom.
You can either use the chat box or you can unmute yourself, answer, and please mute yourself.
Again, this is one of the most controversial topics. I mean, the debate never ends on this.
Yes, the chat box has come up with a few doctors requiring that no, not all of them require a crown. Some are saying few of them require. Some say no, especially for anterior, having well crown structure remaining, not required for anterior. Anterior generally not accept discoloration. Not every time, but patient comes to us once tooth is highly decayed. Some is saying almost all cases. Okay. So that is the answer.
Yeah, okay. Yes, the answer is not every time. Now, when is the next question? So, as some of the doctors have said, the anterior teeth do not require. Why is my presentation? It depends on several factors: the remaining tooth structure, the occlusion, and the periodontal health of the tooth. The remaining tooth structure has to be sound enough. I'm not going too much into the depth of this because this itself would take another hour or so and more than that. So that is not a part of my presentation, but these are just a few points that I wanted to put across. Because again, with a good endo and with a good coronal seal, we also need a good post-endo supportive coverage restoration to ensure longevity of our endo-treated teeth. So if the tooth structure is sufficient enough, if all the functional cusps and the marginal ridges are intact, as somebody had said in a class 1 restoration, yes. If you have a class 1 case, in that case, you need not go for a complete crown. We can manage with an onlay or even a direct restoration. Also depends on occlusion. If there are abnormal occlusal forces coming onto the tooth, if it is a molar tooth, then all those teeth require a full cuspal coverage restoration. The periodontal health of the patient and the hygiene practice, if the periodontal health and the hygiene maintenance is poor, in that case, the full coverage crown should not be given, because in that case, we may be going closer to the gingival sulcus, even if we, of course, subgingival and equigingival margins are contraindicated in such cases. But with supragingival margin, also there is a chance of smear layer over there and a risk of secondary caries. So in such cases, if the occlusion is permissible, in such cases, you should go for a partial coverage restoration. If the anterior teeth are not coming into occlusion, and when I say occlusion, it means all the movements of occlusion. So it should not be coming into occlusion either in lateral or protrusive movement. Any excursions, it should not have any occlusal load on the tooth. In such cases, both upper and lower, central and lateral incisors, we can make do without doing a crown. Because when we are doing a crown on an endo-treated tooth, particularly an anterior tooth, already those teeth are small. They are further narrower at the gingival sulcus. We grind them further. We are weakening the tooth even more for no reason. But again, we can make do with a direct restoration only when we have ensured that we have not left those pulp horns behind. Remember day one, when we had left that horn of the pulp chamber there, if that is remaining, that will lead to discoloration in future. So remove that and you will not require a crown to mask that. Second thing, when you are obturating, your obturation should end at the cemento enamel junction, so that again the gutta-percha does not reflect through the gingiva as well. Because if the gingival biotype is thin, then the color of obturating material reflects even through gingiva. So it has a little darker color compared to the other teeth. If the patient has a gummy smile, it is more obvious. If the patient has no gummy smile, then it's an advantage. So all these things should be taken into consideration while considering restorations, crowns for the teeth. And what type of restorations? Should it be direct or indirect, full coverage or partial coverage, cemented or bonded, post or no post? Again, lot many factors come into the play, but these are the things to be considered when we are planning our full coverage or partial coverage restorations. But as far as possible, nowadays we are moving to minimally invasive dentistry. So a full coverage crown, unless absolutely necessary, should be avoided as far as possible. Where 3 walls are intact, partial coverage restoration like onlay is always beneficial. There are again, I mean, lot many types of, there are so many type of indirect bonded restorations available. And another added advantage the bonded restorations have over cemented restorations, cemented crowns, are the monoblock effect, because they bond to the tooth structure, they impart strength into it to an extent, of course not so much as the original integrity of the tooth, but they do have a reinforcement effect on the tooth with a monoblock effect, which is not there with the cemented restorations or the crowns, because that is where an interface comes in between, a weak link comes in between. So wherever possible, always go for partial coverage crowns with given indications. Post and no post. If you are going for the partial coverage crowns where we are bonded restorations, where we are having a monoblock effect, in such cases a post can be avoided. Another controversial tooth always where I find it difficult whether I should crown it or not, whether I should place a post or not, is the canine, because canines are the teeth which bear maximum load. So I mean, I would prefer to place a post in that, even if I'm not making a crown, if it is otherwise not having an abnormal force applying on it, I would still prefer to put a post and then do a direct composite restoration on the canines, so that it has got some fracture resistance compared against the shearing forces. Let's come to the flare-ups. We discussed the procedural errors yesterday and day before, when we were discussing regarding the instrumentation, irrigation, as well as the access opening, what all things can go wrong, how we can manage or prevent them from happening. So now we come up to inter-appointment flare-up. This also we have discussed yesterday basically, and post-obturation pain. So etiology for the inter-appointment flare-ups, as we discussed yesterday, it is the disturbance of the local adaptation syndrome. So here is a schematic diagram. The bacteria are present here or maybe here, but the body immunity has made peace with it. They both are at equilibrium. This is not more virulent, this is not more aggressive either. So there is no inflammatory reaction. They both are living in coexistence. The moment we introduce our instrument, we are introducing debris, we are introducing chemicals, be it in the form of bacterial toxins or the irrigants. So now basically there is mechanical as well as chemical irritation that has happened here. And now the balance is disturbed, which triggers the inflammatory reaction and hence the flare-up. We also discussed the ways of minimizing or preventing these inter-appointment disturbance in the apical zone and the flare-up. So we can prevent it by controlling our working length, limiting our instrumentation only up to the working length. For that, obviously, a proper accurate calculation of the working length. Side vented needles would prevent the irrigant from going beyond the apex. We are not pushing it beyond. No push-pull filing motion, no vertical motions. Either it is a rotary motion with balanced force technique in hand instrumentation, or we are doing rotary instrumentation, or we are doing reciprocation. And intracanal medicaments that will take care of the inflammation that may take place afterwards. The post-obturation pain can happen due to 3 factors, either biological, chemical, or mechanical. Biological factors being the residual infection, the chemical being the irrigants and the intracanal medicaments. They also tend to trigger some amount of inflammatory reaction sometimes. And mechanical could be because of over-instrumentation. And it is common with warm vertical condensation techniques. Usually from first day to 7 days, there is post-obturation pain to a certain extent present in some of the patients. So proper patient counseling, and that is what usually helps, because of the hydraulic pressure which is created. The pressure tends to cause the flare up in these cases. High points in the restoration, but again this also can be prevented to a larger extent if we have got a proper apical gauging, that is a proper tapered preparation at the apex will prevent excessive material from going beyond. High points in the restoration after obturation may also lead to pain, and this pain will be very characteristic. If the patient has pain only at the time of mastication, that is because of high points. This could happen after the first sitting of excess opening. That time also, if we have not relieved the tooth from the occlusal load, the patient may experience pain in case of necrotic cases, particularly after the cleaning and shaping appointment. So just make sure that the tooth is not in occlusion. There are no heavy occlusal forces applying onto it. Medication, again, analgesics and anti-inflammatories. Antibiotics very selectively, only if required. Cold packs and patient counseling and reassurance. So the take-home message, we come to the conclusion of the endodontic journey of root canal treatment. So as we discussed the triad earlier, it was debridement, sterilization, and obturation. Now the contemporary triad is of accurate diagnosis, proper anatomy and debridement, and a three-dimensional obturation. This is what brings us success. None of these, I mean, any imbalance anywhere, and we do not have good success. So just try and make sure that we are giving our best to the patients. We keep ourselves updated all the time, because there are so many changes happening every day in our field. And thankfully, Corona has given us this opportunity where we could sit back, enrich ourselves with knowledge, spend quality time with our families. So let us all just make the best of it. We absolutely, I mean, everybody is utilizing their time very well. Thank you once again, team IDA, for giving me this opportunity. And I would just like to discuss a little about the emergencies that are happening during this current phase now. Because as we saw that day, I will be repeating the slides of teledentistry again over here. We will touch up on these points a little over here. The pre-treatment emergencies or the inter-appointment or post-obturation emergencies that come. The post-obturation emergencies, we are way beyond that phase now, the inter-appointment and post-obturation phase now. So I'm sure all those inflammations are taken care of. The new things that can happen to the patients now is dentinal hypersensitivity, reversible or irreversible pulpitis, acute periapical abscess, or there could be a traumatic injury, or there could be a cracked tooth syndrome. So phone calls, preferably video calls, or a text and a photograph is more helpful in assessing the severity of the situation. Ask for the symptoms, ask for the history of any COVID symptoms. Prescribe medications, preferably again on text for documentation purposes, because when we are just talking over phone call, it is unless the phone call is recorded, but it's difficult to preserve unless you are preserving all electronic records for the patient. It is better to have a text and preferably take a printout of this text and file it in the patient's file, or if you have electronic records, then make just add this to your electronic records. Make it a point, because the Supreme Court does not allow us to give any telephonic consultation. This is the only time when they have given us liberty given the present circumstances. So documentation is very, very important. And as per the guidelines given by the Indian Society of Oral Implantologists, right now the absolute emergency that is considered is uncontrolled bleeding, cellulitis, and or soft tissue swelling, and swellings that are compromising patient's airway, trauma, and cancers. These are the only emergencies considered at this point of time. So this is the definition of emergency. Apart from these, we should try and manage our cases with home therapy only. And this is the latest guideline that has come yesterday, 8th of April from GDC Nagpur. to the Maharashtra State Dental Council, and this refers to notice for all the registered dental practitioners of the Maharashtra State Dental Council. So this advisory has come from the Government Dental College and Hospital, Nagpur. The emergency treatment in oral medicine and radiology is use of barrier protective gears, the do's and the don'ts they have given, use of all barrier protective gears and use of alcohol-based sanitizer during examination, medicinal treatment of oral precancerous lesion and other oral mucosal lesions, following disinfection protocol like fumigation and cleaning with disinfectant. The don'ts: IOP radiographs are not allowed, extraoral radiographs, CBCT except in case of emergency, and avoid overcrowding in patient waiting area. Conservative dentistry.
Ma'am, this will be forwarded on the all the webinar groups. I
Yes,
have
yes.
this. I have
Yes.
this. I'll forward this entire thing on the
Yes,
webinar 1,
please.
2, 3, and 4 groups.
Yes, yes. Please share it on all the groups.
Yeah, sure, ma'am.
And if we can post this link on the description on YouTube as well, the YouTube
Sure,
page.
sure, sure.
For conservative dentistry and endodontics, caries should be excavated by hand excavation only and dressing to be given. Glass enoma restoration can be done in cervical abrasion cases. Emergency root canal opening if swelling, abscess or pain in the tooth, and re-cementation of inlay. No aerosols, no aerators to be used for any procedures except for an emergency access opening. Surgical endodontics are not to be carried out. Ultrasonics should not be used in endodontics. And there are many other guidelines also given. Oral and maxillofacial surgery. The do's are suturing of bleeding wounds, incision and drainage of severe space infections, emergency extraction of the tooth, correction of acute TMJ discoloration, conservative management of fractures. The don'ts: definitive management of soft and hard tissue trauma, mild and moderate space infections, planned tooth extraction, impacted tooth, or planned extraction of impacted tooth or any planned extraction, biopsy, wire, suture material or bone plate removal, TMJ orthognathic pathology or dental implant surgeries are absolute no-no. Periodontics, the do's: several dental pain, pulpitis in mixed dentition, management of acute dentofacial trauma, management of cleft lip and palate, management of cellulitis or facial swelling. Again, don'ts: no use of aerator or aerosol to be generated, used for any procedures except for emergency access opening, and elective surgical procedures should be avoided. So these are the other guidelines. Dr. Viraj Sanghvi is going to forward it on all the groups as well as on the
It's
YouTube
forwarded.
channel.
It's forwarded.
Okay, it has been already forwarded. So
Yeah.
kindly go through this. So this is the latest advisory we have got from GDC Nagpur for the dental practitioners of Maharashtra. But of course, it can be used as a guideline for the other private practitioners as well.
Ma'am, this is only from the Nagpur Government Dental College, not any main authorities like in Indian Dental Association or MSDC or something is given. It is given by the Nagpur branch to the Maharashtra State Dental Council.
But here is a letter by Maharashtra State Dental Council.
They say that this has been done by Nagpur people. You can also do the same as it is.
Yes.
That is what they mentioned.
Yes, yes, yes. Yeah, so I mean, this is the advisory given by the GDC Nagpur, and it has been endorsed by Maharashtra State Dental Council, but the IDA has not come up with any latest advisory yet. So we would be waiting for that from IDA.
Yeah, but these are approximately the same, I suppose. They are really perfectly all right. They can go ahead with these things.
Yes. And again, this NHS advisory that I had shared earlier, this is pretty much detailed, and it can be again used as a reference. So here they have divided emergency care, designated urgent dental care center, and advising self-help. We do not have the designated urgent dental care center yet, but as per the advisory, we can carry out those treatments in our clinics. That is what I can conclude, right, Dr. Viraj, from the Nagpur advisory? Hello?
Yes, ma'am. We can conclude the Nagpur advisory, not an issue for that.
Yeah. So unless absolute emergency, we do not do any other procedures in our clinics because we do not have any designated urgent dental care center in our country yet. And yes, as I said, the government dental colleges are working. So you can refer your patients there. That is another alternative available. Again, this advisory has been shared already on all the groups. Dr. Viraj, if you could share this also on the YouTube channel, please.
Yeah, sure, ma'am. Because I don't have the link to this, so you can just send me. I'll upload it on the YouTube link and the messages and the groups.
Fine, I'll share the link with you.
Yeah, ma'am.
So according to this, reversible pulpitis tooth pain may be intermittent and associated with stimuli. The tooth is not tender to percussion. Advise self-help, recommend optimal analgesia. If due to a missing filling, advise patient to use an emergency temporary repair kit. We do not have this in our country available. So this does not apply to us, and advise patient to avoid hot and cold food or whatever is the stimulus. Avoid the stimulus and ask the patient to call back if the symptoms get worse. In case of irreversible pulpitis, tooth pain if is spontaneous and longer lasting up to several hours, and maybe keeping the patient awake at night, or pain may be difficult to localize in a single tooth, may last for several hours, may be dull and throbbing, may be worsened by heat, but may also be alleviated by cold. So advise and self-help, recommended optimal analgesia, advise patient to try rinsing with cold water as it can alleviate pain. Advise patient to call back if symptoms get worse. Urgent care, if the patient is in severe pain, uncontrollable pain, which is preventing sleeping or eating, then refer to the designated urgent dental care center. In our case, it would be either a government dental college or our own clinic with absolute safety precautions. Dentine hypersensitivity, it could be a sharp pain, sudden and short-lived. Exposed root surface as a result of gingival recession, advise self-help and advise the patient to regularly apply desensitizing toothpaste to affected area with finger, like an ointment, and avoid the stimuli, cold or acidic foods or drinks. Acute apical abscess, pain is usually localized to a single tooth. Swelling of the gingiva, face or neck, if whether there is fever, listlessness, lethargy, loss of appetite for children younger than 16 years old. So advise in self-help, first thing, recommend optimal analgesia, prescribe antibiotics if we are concerned about the swelling or if there are signs of systemic infection like fever and malaise. Ask the patient to call back in 48 to 72 hours if their symptoms have not resolved. Urgent care, if patient has the infection spreading without airway compromise, or if the patient has continuing or recurrent symptoms, refer them to the designated dental care center for extraction or drainage. Yes, again, when it comes to making a decision, an extraction would gain priority over preserving the tooth in present circumstances. So if possible, extract the tooth rather than doing an emergency access opening. Life is more important than tooth. Tooth can always be replaced. So I feel we should have this approach because we cannot afford to have any aerosols. We do not have the required protective gears, and in spite of taking all the precautions, we are seeing that patients are getting affected, and now it is confirmed that the community spread is happening, and we are the first people who have the risk and the liability of becoming hotspots. So let's avoid being that. Try for extractions as far as possible. Emergency care, if patient has infection which is spreading and or which is likely to compromise airway or severe trismus, refer for emergency care. And there is a note for a chronic abscess draining through a sinus, reassure the patient and advise to continue usual oral self-care. So yes, of course, draining sinuses are always safer. They are not under emergency category. Acute periodontal abscess, periendo lesions. So you can just go through these advisories. Regarding dentoalveolar injuries, the symptoms could be pain, bleeding, swelling, teeth, dentures do not meet together in the way that they did before, tooth mobility, paresthesia, other problems specific to bone fractures, example, nosebleeds, diplopia, that is double vision, or loss of visual acuity. So emergency care here, if bleeding is severe and will not stop within 15 to 30 minutes, there has been significant facial trauma, the patient has had an injury or loss of consciousness, the patient has inhaled a tooth or tooth fragment, refer immediately for emergency care. And this should be in a hospital setup because these patients may require a more advanced life support probably. Advice and self-help: if the patient is not in need of emergency medical attention, advise them to clean the affected area by rinsing gently with mild antiseptic, and if foreign objects are present in the mouth, remove them. Apply ice pack to soft tissue injury and swelling. Apply pressure with a finger to stop any bleeding. Consider recommending analgesia. Do not prescribe antibiotic. There is an advisory for avulsed, displaced or fractured teeth. The fractured tooth or loss of tooth structure, increased mobility of tooth or several teeth as a unit. Tooth looks displaced or elongated. Teeth do not meet together in the way they did before, or empty tooth socket. That means avulsion of the tooth. So urgent care: if a permanent tooth has been knocked out, advise the patient to handle the tooth by its own crown, the white part, avoid touching the root. If the tooth is dirty, wash it briefly, 10 seconds under cold running water. Try to re-implant the tooth in its socket and then bite gently on a handkerchief to hold it in position. If it is not feasible, store the tooth for transportation to the designated urgent dental care center in milk, not in water, in milk. Alternately, transport the tooth in the mouth, keeping it between the molars and inside of the cheek. जहाँ पान मसाला रखते हैं. Refer the designated urgent dental care center. And urgent care: if a permanent tooth or teeth have been removed out of its usual position and it is affecting the bite, refer to the urgent dental care center. If permanent tooth fracture involves a dental pulp, refer to the designated dental care center again. In case of primary teeth, if the tooth has been moved out of its usual position and it's affecting the bite, refer to the designated urgent dental care. If it's been knocked out, advise just self-help at home. Again, coming to the NHS advisory on NSAIDs, the safe analgesics are diclofenac sodium 50 milligrams with or without paracetamol 500 milligrams thrice a day, ketorolac 10 milligram QID, acetaminophen 1000 milligram TID. No ibuprofen as per the WHO guidelines. It seems to be causing more complications with the COVID patients. Antibiotics as per the requirements. Even the NHS advisory does not recommend antibiotics in reversible or irreversible pulpitis without any systemic involvement or swelling. So that was the current advisory, but what do we do post lockdown? This is the major dilemma we all are experiencing right now. I can just say on a personal ground that please avoid opening your clinics until at least mid-May. I do not know how the future will shape up, but as per the predictions, we are likely to experience the peak by end of April or beginning of May. And as I said, we are at we have the potential of becoming hotspots. Let's not become the hotspots for corona and black spot for the society. Let's be more responsible citizens. I know it is a very challenging time for all of us, because many of us have got EMIs and there are staff who are depending on us, for whom we have to pay salary whether we work or not. So all these issues are there, but I'm sure this too shall pass. So that is all I can say. Thank you once again for giving me the patient hearing, and see you all tomorrow with the topic of rubber dam, which is again the need of the hour, and we all will have to use it. I rather say this is an opportunity. We have got a blessing in disguise. This is the time we can rise together as a fraternity. I mean, dentistry has been looked down upon because of a few black swans in our fraternity. But when we all decide, and now we are forced to do quality dentistry, the things which were ideal norms till now have become essential. I mean, using the personal protective equipment at the same time, rubber dam is going to be absolutely necessary for doing the restorative and endodontic procedures. So please start doing it. It is not a rocket science. Everybody can do it, and we will see how to do it tomorrow. I hope I can guide you all through that well. So along with that, I would like to just take your leave for today. Thank you.
Ma'am, there are...
We have a few questions over here as well.
Yes. Yeah, Jason, you can continue.
Yes, sir. Dr. Seema had asked yesterday as well and she wants to know it today as well. We were not able to answer her. Sorry for that. She wants to know what are the different rotary systems and
Yes,
which is
I
the best to be used.
see there is nothing like best. There is no absolute right or wrong uh, for many things in life, but that applies to rotary systems as well. You will have to choose depending on your situation, depending on your budget. And as nowadays we have a lot many systems in the market, reasonable ones. Of course, don't go for those cheap Chinese ones which are not standardized, which we do not know what dubious manufacturing process might have been applied there. So go for the reputed branded ones. There are economical ones also available. Neo Endo, Edge Endo, all these files are pretty economical. They can be used, and rest you can make the. I mean, you need not use extremely expensive files as well. It is not so key. What is expensive is better. So you will have to choose depending on your requirements. And as I said, mix and match. The hybrid approach works. So that way also you can increase the longevity of your instruments, provided you maintain a proper count of each and every instrument usage. And if you want that entire thing, I could not do it yesterday. Yes, it is there on my mind, so that I will give you by tomorrow. The list, the instruction manual, rather the protocol of using those systems, I will share it by tomorrow.
She is Dr. Seema from Webinars 2 Group.
Okay.
Webinars 2.
Okay.
Okay. Yeah,
Yeah,
Dr.
sure.
Seema.
Yeah, Dr. Seema webinars too.
Yeah. Ma'am, there is a question. After obturation, how to achieve occlusal seal on the floor of the cavity?
After I did not
Obturation.
get the question, I mean occlusal seal on the floor of the cavity.
Yeah. So I mean, I think they mean to say how to, the apike, the
Coronal
coronal
seal.
seal which we get on the orifices.
Mhm.
How to achieve that?
With a simple glass ionomer restoration, or you can use a composite restoration, a core build-up material.
Okay.
So if you can you do not want, if you are using a core build-up material, resin-based core build-up material, and you do not want to invest into a separate blue color resin-based material, then what you can do is you can simply buy a blue tint. Just one tint will not cost that much. You can use other blue. I wouldn't recommend brown, because again that would match with the Gutta-percha color. Instead, use a blue color which is easily noticeable when we are drilling through. So just cover, if you are planning to do an all composite restoration, either place a preferably a blue composite. If not blue color composite, then you can place a blue color tint over there, cover it with the composite restoration later on. And as I said, suppose if you do not have enough time to do the permanent restoration in the same visit, or if you are doubtful that the patient may develop some post-op flare-up, in that case, you can just give a coronal seal, that is a layer of 1 to 2 millimeters, just up to the pulp chamber. We do not want to fill up the entire cavity with glass ionomer, just up to the pulp chamber. You can do a nice dense glass ionomer restoration, and on top of it you can place a barrier, either a cotton or a Teflon tape, and rest of the cavity you can fill up with a temporary restorative material. But preferably the final restoration must be done within 48 hours of the obturation.
Okay. Uh, Before the start of a root canal, after caries removal, have the tooth to be built up, then which material to use? Permanent filling material or any temporary filling material?
Again, that depends on the situation. If there is if the now the remaining tooth is at the gingival level or subgingival level, then the moisture control there will be very difficult. In that case, you can go for a temporary restorative material in the form like an expired or a cheap composite that you might have bought and you're not using. Temporarily you can fill that, but yes, you will have to remove it and later on do a proper restoration.
Ma'am, it is said that pro taper gold is the best. What are your views?
I said there are no absolute rights or wrong. There are no absolute greats or absolute douchebags in this world. Applies to everything in life, including rotaries.
Okay. Can we use flowable composites to seal the canal orifices?
Flowable composites you can use, yes. The core build-up materials are available in the form of flowable as well. I mean, the dual syringes with automixing tips are flowable composites. So are you talking about the flowable composites that we use, the unfilled resins that we use for the restorations? That would turn out to be very expensive. So flowables, you can, as I said, just buy a syringe of tint. You can use that as a flow, just very little on the floor, just to differentiate the color.
Okay. Ma'am, there is one question. Can we use Teflon barrier to facilitate re-root canal in the future if necessary?
No way. A barrier means there is an interface. Teflon has no adhesion to any material. That means you are leaving that void over there. So you are, in fact, inviting the retreatment to happen in that case. You are inviting micro leakage to happen. You must not do that. It has to be filled in completely. God forbid if we have to re-enter, that is why we are taking precautions and we are either giving a different texture in the form of glass ionomer or a different color in form of a tinted composite. That is what you can do, because those the glass ionomer will adhere to composite, but you can't keep a barrier in between.
Okay. There is one question which was asked yesterday also. Ma'am, you had mentioned that you prefer going the conventional way for anterior teeth, root canals. Any specific reasons for not using rotaries in anteriors?
No particular reason. Again, I said it is up to the discretion of the operator. There is no particular protocol ki you have to use only rotaries or only hand instrumentation files. The reason I don't use rotary is because already the chambers are wide enough. My file does not have to, I do not have to do a lot of coronal flaring in anteriors. If at all I have to do, I manage it with a flare file, the orifice shapener, or with a gauge Glidden drill, which is again very rarely required because the tooth has got a very nice triangular or an ovoid excess. So that is one reason I do not require those files there. And those canals are wide enough. I do not want too much of instrumentation. I do not want too much of taper. As I said, dentin is the king. Jitna ho sake apne king ko bachao. Preserve as much of dentin as you can. Go for smaller preps. Yes, I do go rotary for a little tapered prep, but again, as I said, I know my irrigation and irrigant agitation protocol. So I am sure that my irrigant is reaching my apex, and that is the reason I follow hand instrumentation.
Ma'am, I think for this, I suppose the individual can choose whatever file system or whatever system he is comfortable with, but he has to be thorough with the basics of which system he is using.
Absolutely.
That is what I feel about this.
Absolutely. You should know the system, you should know the taper, you should know where you are using, you should know why are you using it there. That is most important.
Yeah, unless and until you are comfortable with using rotaries for anteriors, you can go ahead with it, but you should know the basics of it, whatever you use.
Absolutely. See, there are no absolute indications or contraindications. Even in posteriors, you can go all the way with hand instrumentation. There is no harm with that. But it's all about, we need a little bit of taper, and it is easily achieved with the rotary files. That is the reason we are using rotary nowadays more. We need at least 4% taper for the proper irrigant access. That is definitely there.
Dr. Jashan, yeah. Dr. Jashan, from my side, it's done. Any questions from your side?
Yes, there are a few remaining.
Yeah.
After obturation, how to remove the extra GP which is left over in the coronal space before placing any material on the pulpal floor?
Yes. So as I said, either if you're doing lateral compaction, if you have any heat carrier pen in your clinic or the device like Touch and Heat or System B, that is the best. If you do not have that, you can use your conventional instrument, a heated ball burnisher or a spoon excavator, or anything else. Like when I was not having the warm vertical compaction devices with me, I used to sever off with the thin, very small headed ball burnisher. And after that, I used to have, I blunted my straight probe. One of the straight probes, I blunted the tip, I converted it into a plugger, and then I used to pack the GP over there, ensuring that it is properly at the orifice level.
But what I used to do is for, ball burnisher, we used to make it hot on the spirit lamp, cut the excess material, and then the hot material, which is at the GP, which is on the hot at the orifice, we just plug it with the plugger inside.
Absolutely. Yeah, the same thing.
So it completely goes over the orifice and seals it properly.
True.
So ma'am, something from your side is like, which is the material of choice for obturation, which you prefer the material for obturation?
I use the sealer. I use AH plus, and I use non-standardized Gutta-percha points. I use warm vertical compaction in almost all of my cases.
Okay. Now, ma'am, on the financial part, just a thing, using the things which you are for a proper basic root canal, what we do normally, how much would you plan to quote to a patient? The minimum, bare minimum.
Well, my working cost itself would come somewhere around 4,000. So I cannot
Okay.
charge anything below that. Of course, I have to charge above that. So my basic charges start above 5,000 depending on the case. So I never give a fixed rate to the patient. I always give a range, because we do not know. Okay, after the radiograph, we have a basic idea, but you still do not know how things will open up inside. So I always give a range to my patients, depending on the difficulty of the case. It could be in the range of this or this. My retreatment charges are higher compared to the normal root canals.
Okay. So you mean to say, depending on, you can always give a variation, right? From might be starting from 4,500 to go somewhere, depending on the materials which we need to use and everything like that.
There is no upper limit. You can even charge 25,000 for a root canal. Why shouldn't you? In fact, we should. You are putting in so much of your heart and blood and soul into that root canal, and I mean, just being paid 4 or 5,000 is peanuts. It is injustice to us. It's injustice to our knowledge, skill, everything, and our hard work.
Yeah, ma'am, there is a good question. In fact, do GP cones really have an expiry date? If yes, then what happens to the cone that we obturate after the period of expiry written on the packet? Can expiring GP cones be used?
Actually, there is a debate going on regarding the expiry dates of the medicines also. So, according to, I mean, there was a huge and a very big debate recently regarding the expiry. That again, it's a conspiracy by the drug manufacturers, just to increase their turnover. Now, I do not know how much of this is right or wrong. And GP is an inert material. As long as we are not pushing it, of course, it is not in our hands. Sometimes the mishaps happen, but GP does not have an expiry as such. It is a plant extract. It is a natural product, does not have an expiry. What happens to a very old GP point is it becomes brittle and it tends to break. So you you just warm the Gutta-percha point a little and it regains its elasticity. So this is what our old timer teachers used to tell us. Like very, very senior teacher, my guide was one of the first endodontists in India. And sir used to always ask us questions which we had not even heard of, like what is tinker burr? We had never heard of what that burr is. And sir used to give us a lot of these kind of tips because they did not have a concept of expiry then. So old stock, they used to warm the Gutta-perchas and use it again. So yes, there is no expiry as such. एंड अगेन हमको पता है कि ये इस दिन को मैन्युफैक्चर हुआ है, मटेरियल को थोड़ी पता है कि मेरा एक्सपायरी डेट कब है, कल से मेरा काम करना बंद. दैट इज जस्ट ऑन अ लाइटर नोट. I always say the medicine doesn't know that it is expiring today or tomorrow. It will not just stop working overnight कि नहीं चलो मेरा टाइम तो खत्म. It won't happen. So you can use Gutta-percha, but only Gutta-percha, not sealers. Not taking too much of liberty with the patient's health.
Yeah. Thanks a lot, man. Jashan, the final words.
No questions from my end. Thank you once again for a very beautiful lecture. You have put your entire energy into helping all the kids understand that yes, endodontics is easy.
It is easy and it is predictable.
And as I say this, there's one more question comes up. I would be taking this as the last question. Please don't post any more questions. While using the Gutta-percha gun, many a times the excess GP flows in the pulp chamber while removing the tip from the canal. This fills the canal completely. How to avoid this? Because this leads to filling the canal in one go.
It fills the canal completely or it fills the chamber completely? I did not get it. I mean,
I think it should be the chamber, I suppose.
Even I feel it should be the chamber. So it fills the chamber. If you are still new at using this, yes, you are going through the learning curve. Don't worry. Eventually, with time and practice, you will get through this. The same thing used to happen to me also, and a little bit of delay, and the GP used to stick and come out with the plugger. So all these things happen. If you're filling up the entire chamber, don't worry, just use a dry burr. The aerotar itself, of course, right now, so no question of generating aerosols, but you can use aerotar without water spray and just trim off the GP with a round burr up to the orifice level. Because heating the plugger or something again and again and trying and removing that is very cumbersome. You can use a rotary. I mean, a burr, dry burr without water spray, and you can just trim off that excess GP from the chamber.
Yeah, Dr. Jashan, once again, can you just, because there has been a question regarding the lectures to be posted on the webinar groups.
Okay.
So please post the lectures which are going to be there till 13th of April on the respective groups.
Yes, sir, I'll do that.
Yeah, please.
Yep.
Thank you.
So we end the lecture for today. Thanks a lot once again, Neha Madam, for giving your time.
My
We'll
pleasure.
see you again tomorrow, continuing with the session of endodontics. We'll be helping you with rubber dams in endodontics. Thank you. See you again tomorrow at 3:30.
Yeah, thank you so much. Good night, everybody.
Right.